chloroquine, artemisinin based derivatives, quinine and primaquine. Let's now try to understand about chloroquine as a molecule. Already in the classification, we learned that it belongs to the 4-aminoquinolone group. Let's try to understand what is the mechanism of action of chloroquine. This chloroquine basically acts on the erythrocytic forms. It can also act Chloroquine acts on the erythrocytic forms. It has no useful gametocidal action. It's a very mild gametocidal. It has very mild, but that is not much clinically useful. It doesn't act on the pre-erythrocytic or the hepatic stages. Let's try to understand the mechanism of action of chloroquine. What is the mechanism of action of chloroquine? Hemoglobin in the RBC. Hemoglobin in the RBC. This is the RBC, what we see, the pink one. This is the green one, is the plasmodium. The hemoglobin in the plasmodium taken up from the RBCs reaches the foot vacuole. In the foot vacuole, this hemoglobin is converted to heme. This is further, heme is toxic, so heme is converted into hemozoin. Heme is converted into hemozoin, which is a non-toxic form. All this happens in the foot vacuole. Chloroquine enters into the foot vacuole through certain pumps. This conversion of heme to hemozoin is inhibited by chloroquine. So toxic heme remains in the foot vacuole. Not only that, chloroquine also can combine with heme to form a chloroquine heme complex, which is also toxic. So plasmodium nutrition is basically hemoglobin in the acidic vacuole The chloroquine shall concentrate in the acidic vacuole of the plasmodia. This is going to affect polymerization of the toxic heme, and also it will generate chloroquine heme complex. Both chloroquine heme complex as well as the toxic heme will damage the plasmodial membranes. Thus chloroquine will be able to kill the plasmodium parasite. There are other drugs also which act to the same mechanism, like quinine, amidoquine, mefloquine, lumefantrine and paranardine. Means most of our anti-malarial drugs have a similar mechanism of action where they inhibit the conversion of toxic heme into hemozoin. What is the mechanism of resistance? We already understood chloroquine, which is in the food vacuole, is effluxed outside through the PFCRT pump. PFCRT pump. This is the efflux pump which is going to pump out chloroquine. So chloroquine resistance is widespread. It is basically because of the efflux pump PFCRT. It is pretty much widespread with falciform. In India, more than 80 to 90% of the plasmodial vivax, plasmodial falciform species are resistant to chloroquine. For vivax, it's between 40 to 50%. What is recrudescence? This is one more terminology which we hear when we are talking about malaria. What is recrudescence? Due to incomplete clearance of the parasite, again and again the patient will have malarial symptoms. So here we have all this is because of chloroquine resistance, or we are giving a drug for which the parasite has developed resistance, where it's not completely able to clear the parasite. Relapse will be predominantly due to hypnozoites. When we understood the life cycle, we are talking about the sleeping plasmodiums, plasmodial parasites called the hypnozoites. When the hypnozoites reactivate, they can cause a relapse. So, let's try to understand a little more about chloroquine. Chloroquine also acts on other species, other microorganisms like Entamoeba, Giardia Lambia. Entamoeba causes amoebiasis. So, we use this in the treatment of giardiasis, extraintestinal amoebiasis. Also, it has anti-inflammatory property, hence we use it in rheumatoid arthritis. It is a local irritant, it has got a local anesthetic property, it has a weak smooth muscle relaxant property, minor antihistaminic role, and it also has got a anti-arrhythmic properties. If this drug is directly injected, it can depress the myocardium, also causing hypotension. What are the other features of chloroquine? If it has got a good oral absorption, it has high affinity for the structures, especially those which are colored, like the melanin, the nuclear chromatin, retina, liver, kidney, lung, skin, leukocytes, spleen. What does that mean is adverse effects are going to be common with these structures. Like in retina, it can cause blindness, melanin, grey coloring, greyish discoloration of hair. So we'll try to understand this in context with adverse drug reactions. What about the metabolism? It's excreted in liver, metabolized in liver, excreted in urine. It is a drug which undergoes extensive tissue binding. It can be given both orally as well as parenterally. So what does extensive tissue binding do to this drug? Because of extensive tissue binding, we need to give a loading dose. We need to give a loading dose. It's a very cumulative drug. The T-half is around 214 hours. Very high volume of distribution of 13,000 liters. So we need a loading dose. One of the questions what we can have is why need chloroquine loading dose. It is just because it has a high volume of distribution, it's a very cumulative drug, and it has a high T-half of 214 hours. Before we understand about the adverse drug reaction, because we just now learned about the loading dose, let's try to understand actually how the drug is given. So initially, if you look at the first dose, we give 300 milligrams. We give 500 milligrams of chloroquine phosphate, first dose, 2 tablets. After 6 hours, we shall give another dose. So this shall be the loading dose. On day 2, that is 24 hours after the first dose, we shall be giving the second dose, and the third dose will be 48 hours after the first dose. So we understood about the loading dose. Where do we use chloroquine? We already learned chloroquine as used in the clinical cure of malaria. That is, for treating malaria caused by ovale falciform vivax and chloroquine sensitive falciform malaria. For clinical cure as well as for suppressive prophylaxis also we can use. We can also use for extraintestinal amoebiasis. So for clinical cure of malaria, extraintestinal amoebiasis, rheumatoid arthritis, we use it in rheumatoid arthritis because of its anti-inflammatory action. In SLE, systemic lupus erythematosus, sarcoidosis, discoid lupus erythematosus, porphyria, and in lepra reaction. It's also used in infectious mononucleosis. Let's try to go back and understand about Let's try to go back and understand Let's try to go back and understand the adverse effect of chloroquine. So already we know the chloroquine can be taken orally as well as parenterally. So if a patient takes the drug orally, it is a highly irritant drug. It's a quinine. It's a highly irritant drug. It can cause nausea, vomiting, anorexia, epigastric pain, uneasiness, and headache. We also understood that it has high affinity and it binds to structures like melanin, retina. It binds to nuclear chromatin. So in the eye, it causes reversible loss of accommodation retinal and macular degenerations. It can also form corneal deposits. There can be loss of hearing. Graying of hair, photoallergy, rashes, myopathy. Given in a high dose in CNS, it can cause seizures, insomnia, transient depression. We also understood it's a myocardial depressant. It can cause hypotension. It can also cause arrhythmias. So, there are few places where we have to exert caution before we give chloroquine. Like in G6PD deficiency, liver damage, severe gastrointestinal intolerance, neurological, retinal or hematological diseases. You can also precipitate seizures, porphyria and psoriasis. We usually don't combine chloroquine with mefloquine, amiodarone and other antiarrhythmics. These adverse effects of chloroquine happens on a short course of treatment. If the same chloroquine is going to be used for prolonged duration, like in rheumatoid arthritis or systemic lupus erythematosus, there is going to be severe damage to the eye. It can cause loss of vision. It can cause corneal deposits, discoloration of the mucous membrane, graying of hair. It can rarely cause cardiomyopathy and peripheral neuropathies, neuropsychiatric disturbances. Let's try to understand a little bit more about the retinal damage. One of the adverse effects of chloroquine is bullseye maculopathy. Let's try to see what a bullseye maculopathy is. So, bullseye maculopathy happens due to chloroquine, hydroxychloroquine and clofazimine toxicity, bullseye maculopathy. So, what is bullseye maculopathy? Macula in which there are circular bands of different shades of pink, white and orange are visible. This looks like a bull's eye. So, the drugs which can cause this are chloroquine, hydroxychloroquine and clofazimine, which is used in the treatment of tuberculosis. So, today we understood about chloroquine, hydroxychloroquine, its mechanism of action, what is a mechanism of resistance, pharmacokinetics, its uses, its adverse effects, both in short term and in prolonged therapy. We also understood what are the species, and we also understood what a hypnozoite is, what is a relapse. So, we'll continue with this in the next class.